My name is Pradeep Gaul. I'm the CEO of Solve.Care Foundation, and I'm delighted to be here. We have a lot of material to cover in 30 minutes, so I will cover it with some degree of speed. And if you have any questions, please stop by and we can chat later. I'm not going to talk about regulatory issues around blockchain. I'm not going to talk about the technology maturity. I'm going to talk about a specific application or use case that's really driving a lot of dialogue in the US, which is healthcare. My background, I spent 25 years in healthcare. Yes, I started when I was 7 years old. What are we covering today? We're talking about a specific problem in healthcare, and that's healthcare payments. And healthcare payments are unique in that they bring a degree of complexity that, unless you're in the industry, would sound like a fictional problem. So let me explain. The scale of the problem in the US really is staggering. And I wasn't joking when I heard the number 360 billion in waste. We would have a really happy year if the only amount of waste we had was 360 billion. That would be a wonderful year. Because the cost of healthcare in the US, in terms of waste and fraud and inefficiency, is over $1 trillion a year, and we know it. This is a well-documented number, and it grows each year. So 360 billion sounds like Christmas. Let's talk about what's happening. In the US, we spend $3,200 billion a year in healthcare. These numbers are 2015 numbers. We don't have 16 or 17 numbers. We expect they'll be between 3.5 and 3.6 trillion this year. These numbers are staggering. 20% of our GDP is healthcare now, bigger than any other industry and bigger than most economies in the world. This is where it gets spent. $1 trillion goes to hospitals, and about 500 billion goes to physicians who are not affiliated with hospitals. And the rest is just broken down into miscellaneous items. But I want to bring your attention to the last item. 42.6 billion is spent on government trying to administer healthcare each year. That in itself is a staggering number. 42 billion is spent not on healthcare, but administration of government programs each year. Now let's go to why it is so expensive. Healthcare in the US and in most developed countries is a third-party payment model. I go to the doctor, you pay the bill. But just in that statement, I now introduce steps before I can make payment. I need to verify that you are eligible to receive services. I need to verify that the services you said you received, you actually received. I need to verify the pricing of the service you received. I need to verify that you don't owe part of the cost of the service. Perhaps you do. I need to verify that the volume discount I'm entitled to have been applied to the pricing that I received from the doctor. I have to verify exceptions like medical necessity or rural care or elderly care. And I have to then collect payment from everybody and make sure the right person gets paid. That's just a happy path. That's a good day. I was CIO of a major insurance company, and I had a startling revelation one day. Many times, the cost of paying a bill is more than the amount of the bill. What other industry does that? Imagine you go to the retail sector and you buy a sweater, and the cost of credit card transaction is more than the sweater itself. Would not make you a happy consumer, but we do that every day. Why does it happen? First is there are multiple payments. I, as a patient, have a copay. I, as an insurance company, have a payment responsibility. You, as an employer, might have a share. We might have supplemental insurance, on and on and on. Multiple payments make up. Single bill can result in multiple payments. But once I made the payment, then the fun starts. Then we got to review, in retrospect, whether was this medically necessary payment? Was this overbilled to me? Did you bundle services to make them look more expensive than they really are? Was this service really eligible to be given to this person? Well, maybe they were supposed to pay it out of pocket. Or was the quality of service such that the payment is merited, which is the latest trend in the US? ACOs, Obamacare all talked about quality of service-based payment. Introduces this question of, did you get the quality you expected before I pay it or after I pay it? Then there are adjustments. Oops, we overpaid. We have this model called pay and chase. You got to pay the provider to keep the hospital open, but then you chase after them for overbilling all the time. So you pay and then you chase. You do pricing adjustments, you do cost-sharing adjustments, you do volume discounts, you do credits and advances, and you do incorrect deductible adjustment. These are the reasons why healthcare payments are very complex. And that's what we're trying to address with blockchain. This is a happy path of a provider getting paid. I want to go to the doctor. They have to check. You cannot probably read it, but there are 13 steps between the day a patient calls to see me and the day I get paid. And the cycle is 90 days long on a good day. A senior health economist in the US, who is an advisor to us, did a research study for one government program in the US called Medicaid, which is a healthcare program for poor. The cost of this program to the US taxpayer is $553 billion a year. That was 2015 numbers. It has grown since then. We just don't know how much. He estimated by studying 5 states that 100 billion of the 553 billion is fraud, waste, inefficiency, duplication, unnecessary services, and overbilling, 20%, and growing. So if we can just take one program in the US, one single program, not to mention Medicare, mental health, childcare, juvenile justice, and so on and so forth, there are over 70 programs. So if you take one of those 70 and we fix it, that's 100 billion a year in savings. Not on care, not on reducing access to care, but on simply stripping out duplication and waste. What is the root cause? The fundamental root cause is third-party payment model. All of us are out of sync with each other. You go to the doctor, I have no visibility into what you went and did. I get a bill, you don't have any visibility what the doctor billed me. I reprice it, you have no visibility into the pricing contracts. The doctor appeals it, no one has a visibility into what they're appealing it on the basis of, and so on. Everybody is in a silo. Everybody's arguing their case. There is no commonality of information. So then comes Obamacare, and that says, you know what, we're going to build these HIEs, health insurance exchanges, to bring transparency. Great idea, doesn't work. Why? Because I don't want to share information. As an insurance company, that's my lifeblood. As a doctor, that's your lifeblood. Control over information gives me power. So Obama can beat his drum all they want. I'm not going to share information. So we spent God knows how many $1 trillion on implementing Obamacare. End of the day, none of the HIEs work, not one, because it's not in my interest to share data. That's the problem with healthcare in the US. So let's see what we can do about it. Our vision is very clear. It is to replace centralized systems that do after-the-fact analysis with real-time currency that can do real-time analysis. Before we jump into the technology, I want to talk about something. Yesterday, we presented in Baltimore at the Center of Medicare and Medicaid Services to them the concept of an intelligent token. These are the guys who administer both Medicare and Medicaid in the US. They are the ones who spend about $1.5 trillion of our money each year, and not very well managed at the same time. And the notion here was, you, Mr. Governor of the state of Arkansas, or you, Mr. Administrator of Medicare, if you could just take the overutilization of care out of the system, we would probably balance the budget in 10 years. So with that notion, there is a demand. The question of problem isn't disputed. No one in the US needs to be told that we have a problem. The question is, what is the solution? So we are proposing an idea of an intelligent healthcare currency that does certain things that systems do not do. First, it does automatic reservation of payment. When I go see a doctor, it reserves a certain amount of money in my wallet to say, when I do receive services, I will be paying for that. It's something as simple as $20, but it eliminates a collection issue that a doctor has. It has an ability for the insurance company to commit to pay as part of a pricing contract, a smart contract, if you will, that says, if you give John Doe services, I will pay. The third is proof of service. But you, Mr. Doctor, must give me a proof of service. You must give me enough evidence that you have delivered the service. The fourth is it must give me proof of pricing. When I say I'll pay, I'm giving you a pricing contract, which you know as a physician transparently what exactly you're going to get paid. The next is proof of payment. How do I make sure that all other parties know that I made the payment that I said I would, so there is no more question of audit and reconciliation? The next one is consent to audit. I need to be able to audit as a government agency, as an insurance company, as an independent civics agency, that things are happening as they're supposed to happen, because ultimately it's my money being spent by others. And then automatic adjustment. This is the key part. As a physician, I would agree that if I have been found overbilling, overcharging, overbundling, or providing unnecessary medical services, you have the right to recover. those funds automatically from my wallet. Those capabilities of an intelligent currency redefines healthcare in a very fundamental way. How does it do that? First, we are proposing that the payment models be decentralized to relationships. There is a clear relationship between a doctor and a patient, between a doctor and an insurance company, between a doctor and a specialist, between a lab and a patient. These relationships today are in centralized systems. With blockchain, you can create well-defined relationship patterns, encode them in the smart contract, and move them to the edge logic. In other words, I don't need to go run back to the insurance company system to validate my relationship and my rights of my relationship with the doctor. So there are many relationship pairs possible, but there are 5 that really jump out. Insurance-insured relationship, patient-doctor relationship, doctor-insurance relationship, specialist-doctor relationship, and the employer-employee relationship. These are the key relationships where money exchanges hands. And if we can define and encapsulate them in contracts that are enforced by the currency, the need for central analysis, central approval, central payment literally goes away. So what does that mean? Let's imagine a scenario where I, as a patient, go to visit a doctor. Today, the doctor would call the insurance company, sit on the phone for 20 minutes, and figure out if I have insurance, what's my copay, what's my deductible, what's my coinsurance, and so on and so forth. You really don't need to do that. There is no reason why he can ask me directly, what is the contract between you and your insurance company? And I can validate that, and it's immutable, so therefore I can check it, and I don't need to know anything more than here is your copay and your deductible, and it is up to date. It eliminates enormous administrative burden on hospitals and doctors. Pricing. Now, today as a patient, I have zero pricing knowledge. I do not know when I go see a doctor what the bill will be. I have no idea. But if I have pricing availability of the contract between insurance company and doctor, where I can say, how much is my visit worth on the list price and the discounted price and cost sharing model, you suddenly have complete transparency that every politician talks about, but we have never achieved in our history. Same is with necessity. Insurance company wants to make sure that I'm not getting services that I don't need. I really don't need a mammogram. It's an unlikely use of healthcare. But if that is being given, I can stop it before it is actually delivered. I can deny services by simply coding in the smart contract what exactly are you entitled to. It's personalized to the needs of the individual. If I have a child who has diabetes, juvenile diabetic treatments are very different than adult diabetic treatment. Today, to do that, I need to assign a case manager who then directs the physician what they can or cannot do. You don't need that. You can replace that with a necessity contract, which can be personalized to the individual. And the last is relationship. My relationship with my spouse, her ability to access care under my insurance company, the insurance company's relationship to my child, who is now a dependent upon my program. These are relationships that are very complex, but they're only complex because they are always out of sync. If you can evaluate those relationships at the point of service, at the doctor's office, not at the central insurance company office, it changes everything. And the last but not the least is a concept of proof of service. So the idea and the vision is that the currency itself is smart enough to move the logic out of the centralized systems and can do verification, proof, commitment, agreement, execution at the point of service, not through a centralized system. One of the fundamental problems in healthcare is billing. Doctors don't know what to bill, and insurance companies don't know if the bill is accurate. And we spend tremendous amount of money trying to validate the bill accuracy. But instead of doing attestation-based billing, where I attest to having delivered somebody's services, and you now have the burden of proving that I did what I said I did, you can reverse it. And you can say, let's do a proof of service billing, where there are enough events in the blockchain ledger that I would need to accumulate before I can send a bill. If there was never a scheduled visit, if I didn't issue a prescription, if I didn't issue a diagnosis, if I didn't do a referral, it's unlikely that the patient ever came to me. Those events can be captured from a shared ledger, so we can actually say, yep, enough events have occurred for me to be sure that the service was delivered. Imagine a scenario where today in the US, pop-up shops happen all the time, particularly in Florida where I live. You end up with a durable medical equipment provider opening shop, billing Medicaid 10,000 wheelchairs for people who recently passed away or never needed them, collect the money and close shop and go away before my fraud investigation system catches on to me. And I'm already in the next building with a new name, billing you for crutches the next day. Happens all the time. Sophisticated fraud happens all the time. It's because the lag time between me billing and collecting and you chasing me is too long. I can move to Bahamas and be living a happy life by the time you figure out that I never sold those wheelchairs. Those kind of things lack proof of service. That's how fraud occurs. So if we can implement proof of service through a blockchain ledger, it changes the dynamics of fraud completely. So this is an example of the type of events that can be used to compute proof of service. Scheduling event, treatment event, prescription event, referral, lab test, follow-up visit. These are real-life events that actually compute a score that lets me as an insurance company pay the bill. Let's move to review. One of the biggest costs of health insurance, particularly in government, is review. Of course, you pay first because you don't want to have access to care limited. You don't want to drive doctors and hospitals into bankruptcy, so you want to pay them because 95% of them are honest, legitimate providers. But there are 5% that will abuse the system. So you pay everybody, and then you try to catch the 5%. Instead of doing that, let's actually use proof of service to pay the 95% and deny the 5% and say, we don't have sufficient proof of service, so we're not going to pay. And that changes the model of, instead of pay and chase, stop and check. And that's a huge shift in the US. And I think worldwide, because the problem exists not just in the United States. I was working with the Chinese government on trying to design their third-party administration model, and it's even more complex in the US. It is not that different. It's just that it's not that pervasive. And it gets bigger, it'll have the exact same problems the US has. Point of view here is that a proof of service is an automatically computed score of all the actions that have taken place between the doctor and the patient, doctor and the lab, doctor and the pharmacy, patient and the pharmacy, for me to actually know that this is a real transaction based on real events. Finally, the last thing about an intelligent currency would be an escrow-based payment model. Today, I, as an insurance company, am the escrow agent, right? I am committing to pay you, Mr. Doctor, if you deliver services to my patients, as long as you can prove to me that you have delivered those services. That is who I am. But really, end of the day, my function is very complicated, only in the sense that I have no information as to what's happening between doctor and patient. It would make a lot more sense if I put those escrow money in the patient's wallet, which cannot be moved till the proof of service is computed. And I'm out of the picture. I don't need to know anymore. Because if there is enough proof of service and the pricing contract is coded into the wallet, why do I care? It's the same thing I'm going to do, except it's done a lot more efficiently between you and the doctor. So it allows me to delegate payment authority without losing control. I can still audit. You will consent to auditing my transactions, or me auditing your transactions, pardon me. But I would only audit the 5%. I wouldn't audit every single transaction. Because one of the unwritten jokes in health insurance in the US is you are transacting billions of transactions a year looking for the needle in a haystack, because 95% of the transactions you're not going to even pay attention to. They're just regular. It's the 5% that I'm looking for, but I don't know which 5 to look for. So a proof of service score lets me focus on things that look suspicious and not worry about the rest. So in an escrow model, the insurance doctor payment can actually be a shared wallet that allows a doctor to withdraw money based on proof of service. Patient doctor, same way. The patient will automatically commit to paying copay, co-insurance out of pocket if they have received appropriate service, which would be approved by a central contract saying, a distributed contract saying, you have received enough service, now you need to release 30%, 70%, 100% of the payment. Same with employer-employee. There is a whole industry in the US talking about how employers should incentivize employees to spend their healthcare dollars wisely, because ultimately most of the healthcare is funded by employers. Same model. I, as an employer, will fund my employees to do certain things. If you go to the gym 3 times a week, I'm going to pay 10% more of your premium. I'll reduce your cost-sharing component. I will put more money in your HSA. There are many things I can do as an employer to incentivize my employee behavior. The problem is I can't track it. So this helps me track what the employee's behavior is and do they really merit the extra incentive from me. Then there is the agency patient. I am a Medicaid agency, and I want to really stop people from going to the emergency room to get Tylenol. Again, another urban legend. Medicaid recipient goes to the ER, gets a Tylenol for headache. I get a bill for $1,000 as a Medicaid agency. Not unheard of, happens. Not as frequently as it used to happen, but still happens. It's called overutilization of services by Medicaid population. I can change that behavior by saying to them when you're at the ER, if you are only prescribing a over-the-counter medication, don't prescribe. Send them back to the pharmacy outside 3 feet from the hospital and let them buy it using a card. So there are many ways we can optimize utilization in programs like Medicaid and Medicare if we can do real-time evaluation of pricing and service contracts. And finally, agency doctor. This is a really tricky problem. As a Medicaid director, I must balance access to care with appropriate payment for care. Typically, you're challenged with the notion that there is some rural community in Kansas where there is only one hospital, one doctor, and you know they're overbilling you. You know they're doing fraud, but you can't stop it because if you shut them down, there is no care. So you have to balance access to care with payments. But it does not need to be so binary. It does not need to be, well, we must accept fraud as a way to provide access to care for citizens. Again, for each transaction, you can do a much more of a binary decision. Today, we can't do that. So those are the fundamental shifts that a blockchain model brings to US healthcare. So summary of key characteristics of an intelligent health currency would be the following. It would have a stable monetary value, meaning the doctor, when they receive this currency, digital token, coin, whatever you want to call it, has no fluctuation in value because you cannot have variable risk for the physician. It has to have guaranteed redemption, meaning I can redeem when I want, if I want, and at any point I want. It needs to include the proof of service model, which allows me to calculate the probability of the service having been given beyond the attestation by the doctor that they really did it. It needs to have administrative cost bands where I know as a Medicare director, as an insurance company CIO, that my cost will not exceed X percentage. Typical cost of administration for insurance today is 11%. So if I am paying out, say, $5 billion in claims a year, I know I'm spending $550 million a year on pure back end. It's too high. Every single board that I have ever reported to has always said, why is it so big? Why can't you bring it down to 1%? And the answer is, I can't because the systems are too siloed. But with a distributed currency, you could get down to 3%. Immutable audit trail, which is critical. Everything in healthcare must be auditable. Privacy is clearly an issue, but auditing is a bigger issue. And then finally, access control. And I saw earlier a great presentation on the idea of vaults, I believe, lockers. The same concept. I, as a citizen, as a patient, as an employee, can give access to my doctor for one piece of information and my insurance company for another piece of information. That is critical. I need to be able to control what information is shared with whom. So the notion that the information, the events themselves are more valuable than the content of the event. As an insurance company, I care a lot more about the fact that you went to see the doctor, a lot less about the fact what he told you. I don't need to know the diagnosis he gave you. I need to know that you went and that he saw you so that I have proof of service. I will get the information about billing later, but I need to know that you went. A schedule happened, a visit happened, a referral happened, a prescription happened. I don't need to know whether he prescribed Tylenol or something else, but I need to know that he prescribed something. So we can separate events from content, protect consumers' privacy while still giving transparency to the system. That's what an intelligent currency would accomplish. And then finally, the escrow function. If we can escrow payments, we replace the insurance company's footprint almost entirely. In this world of intelligent health currency, when we look at the impact on call center, we did a model and we realized that majority of the calls that an insurance company gets around eligibility, vast majority, 70% of the incoming calls are eligibility calls. There is no reason for those calls to occur. So you would eliminate the single biggest expense from an insurance company perspective and from a doctor perspective, just by coding eligibility in a contract that is visible to doctor, patient, and insurance company. All three can see the eligibility data. You would eliminate the single biggest administrative cost. The second part is it fundamentally changes healthcare in the sense that I, as an insurance company or as a Medicare director or as a Medicaid director, do not need to sit between you and the doctor. I can sit on the side and let you transact, and based on the currency's behavior, can focus on the 5% abuse cases and 95% I don't need to be involved in at all. even in eligibility, in treatment, and in payment. Complete redefinition of cost. And finally, in terms of just cost of administration, government spends $46 billion a year in IT systems and administering call centers, and they don't talk to patients and they don't talk to doctors. They just spend that money on back-end systems. And the same is true for employers in every insurance company. Our cost of administration is staggering, not the cost of care. We can complain about cost of care in pharmacy all day long, but it's about the cost of administration is staggering. This eliminates majority of that cost. So our proposal is not whether blockchain has the potential or whether blockchain will be adopted, but rather how and when. We are looking at this as a very well-defined use case, as a very well-defined problem with a very well-defined solution, which now needs the technology implementation to make happen. A little bit about the company, 2 slides. Solve.Care was founded after I have been in healthcare for 26 years, IT, worked for government, I've worked for insurance companies, I've worked for employers, I've worked for health plans, I've worked for hospitals and doctors. It is the same problem looked from a different angle. We all have siloed systems that are incapable of dealing with the real-time nature of healthcare. So we are designing at Solve.Care a platform that takes this siloed approach and gives you a decentralized network to connect. Key point, we will never replace the core systems. If you come to me as an insurance CIO and say to me, I'm going to rip out your eligibility system and replace it with something in the cloud, I'm saying, go away. Not going to happen. But if you come to me and say, I will make your eligibility transparent to the doctor and the patient, I'm very interested. Because you're not talking about replacing me, you're talking about augmenting what I cannot do today. So it's a complementary platform that sits alongside a Medicaid eligibility system or a Medicare payment system or a central insurance company system. That's the vision. It has 5 parts to this. A care wallet application that engages the doctor, the patient, the employer, the employee. A care card, which is a downloadable application in the wallet that lets you do specific functions like make an appointment, get a prescription filled, send a lab result to the doctor to look at best care practices and so on. Third is a care coin, which is the intelligent currency we just talked about, implemented in the form of a stable monetary value coin that has the ability to do real-time contract enforcement. And last is a care marketplace where the community, the insurance company, can publish specialized care cards, for example, for juvenile diabetes or for care management of multi-chronic cases. Bilateral amputee diabetic who is in a hospital has failed kidneys and needs dialysis. Those are the cases that cost a lot of money. Those can be managed much better by an automated system rather than dedicated case managers. So we have a mission of reducing the cost of administration in the US from 30% to 3%, which is a bold statement. In effect, we are saying, let's not spend $1 trillion, let's spend $100 billion a year, and that would be enough to administer care. It's about decentralizing healthcare and benefit administration so that I, as an insurance company or as a Medicaid director, do not need to be in the middle of every step. It's about engaging the patient with information they today do not have, starting with medical records, but much more importantly, with my options and actions around care. Fourth is reducing the administrative burden on the doctor. Today, every doctor in the US will tell you that they spend over 30% of their time on the phone with insurance companies, not seeing patients. That's an unacceptable burden on them. There is a true focus on accurate and timely payments, so we don't do pay and chase. We stop and verify before we pay. And then it's taking a real sledgehammer to the fraud, waste, and abuse, which is an ever-growing problem. I talked about fake billing, overutilization, overbundling, and so on and so forth. And really, ultimately, it's about bringing transparency and accountability to the system through shared ledgers. So DLT or blockchain or whatever the new term we will invent for this idea, the concept makes perfect sense that we should look at creating transparency between the key stakeholders. We're not talking about making public records available to some kid in Indonesia who doesn't need to know. But we do want to have the lab, the pharmacy, the doctor, the specialist, the insurance company, the employer, the employee share appropriate information so that we can all contribute to healthcare the right way. And that's the vision behind our platform. This is a little bit about the company. If you would like to come visit or chat or challenge what we are doing, we'd welcome your feedback. Solve.Care is the name of the website. And we would welcome any commentary from a European perspective or from a technology perspective. So thank you for your time. I appreciate it. And we'll chat with you later today. Thanks.